All right, so now for this lecture, we're going to talk about tissue transplantation. And we also have, of course, stem cell transplant. Um, the transplantation is the process that you use in order to replace a organ, such as a solid organ, your kidney, for example, or liver, that is damaged with a healthy version of it. And we also have the ability to transplant bone marrow cells, and oftentimes these stem cells from the bone marrow are going to be used to replace a primary immunodeficiency, such as a deficiency of FOXP3. And both of these are going to have different issues with them. Rejection, of course, is going to be the main, so you can get rejection of the graft symbol. And then with respect to the bone marrow transplant, you can have graft versus host disease. And what that means is the cells that are donated, those stem cells, will start to cause disease and target the recipient cells. Now, in order to do this, there's a lot of things that go into it. Of course, if you have a burn, you can do a self-graft with your skin cells, for example. If you have an identical twin, that's the best outcome or the best prognosis because your twin can donate an organ to you, and since you're identical, the likelihood of it being rejected is very low. Apart from that, everything else is allotransplants, and so you're going to have to go through the process of matching. So you're going to want to match the different HLAs because those are, of course, going to be antigenic because they're different from person to person. And so tissue typing is very important. And then also, most allo transplants are going to have some form of immunosuppressive treatment, and typically an individual will be on this treatment for the remainder of their life. And so, again, it all comes back to wanting to prevent rejection of the transplant. And after you prevent rejection, then you can sort of manage the more long-term effects of the transplant. And so just a few definitions. Rejection, of course, is going to be when the recipient's immune system targets the transplanted organ. And so this is the recipient. And then the organ gets destroyed, rejected. And we've already talked about different types of transplant. Autologous means yourself. The most common self is going to be a skin after some trauma. Syngeneic, of course, is going to be a tissue from an identical twin, and then all of the others are allo or allogenic transplants. And these are the ones that have to be HLA matched. And also, you can have cadaveric transplants, and these are tissues from a dead person, for example. And xenogenetic transplants are between species, and we briefly discussed why pigs who have organ sizes similar to ours are often thought about with respect to the xenogenetic transplant. Okay, so with respect to solid organ transplants, the option of doing a transplant is going to be when a person's organs fail to function properly. And you're going to have a minimum set of criteria. So when is a transplant needed? You have to ask questions like, is the damage irreversible? Are there alternatives to transplant? So irreversible. And no alternatives. And in addition, when you do the transplant, this is treatments. And post-transplant, you want to make sure that the disease does not come back. And so when you have a person who has Goodpasture's syndrome, and then they are going to attack the basement membrane of the kidney, if you give a new donor kidney to that patient, the likelihood of the new donated tissue to be attacked by these autoimmune response is very high. And so that would be not a good time to do an organ transplant. In addition, you want to minimize rejection. So you want the donor recipient and they have to be ABO matched, so their blood types have to match. They must also have no antibodies to the donor's HLA antigens. The recipient must not have anti-donor. And then the donor also has to have as close as possible match for HLA. So best HLA match. And then the patient must also be on some sort of immunosuppressive treatment program. Now, with all of these tissues that are going to be transplanted, again, the main risk is for rejection. Okay, so there's only so many donated tissues, and so when you go through this process, you want to make sure that the recipient is a good match for that tissue and will not reject that tissue. Now, there are various types of procedures that are going to be used for different donated tissues. The cornea is a unique tissue because, again, that's a privileged site, and so it's going to rarely be seen in the immune response. And so for corneal transplants, there's no need for immunosuppressive treatments. In addition, liver transplants can be done with HLA mismatched donors and recipients, and it's not really clear why. However, heart transplantation is almost always done when you have heart failure, and the person will die without the transplant. And there's not always time to wait for a heart transplant for an HLA matched donor. And often the first heart that becomes available is going to be given to the patient. And so we have liver, no HLA, matching is needed with a reason unknown, or just don't understand, reason unknown. Heart is usually emergency, cannot wait for HLA. So strong immune suppressives are used. Okay, so let's just talk a little bit about the mechanisms of rejection. So the first mechanism is what is referred to as hyperacute rejection, and this takes place within hours. So this is very, very fast. And hyperacute rejection is going to be caused by antibodies. And these antibodies occur within hours, and so very good hours. And so this means that this is a memory response or a B1 response, natural antibodies. And so this is going to be caused by, classically, by the recipient having an anti-ABO blood group or HLA class 1 antigens targeting the grafted tissue. And so basically, your recipient oftentimes is not healthy, had maybe some blood transfusions, maybe exposed to antigens through those types of transfusions. They may have also formed anti-HLA class 1 antibodies after exposure to allogeneic lymphocytes during pregnancy or even a previous transplant. So the antibodies are going to be memory and they're going to trigger a type 2 hypersensitivity reaction. So this is cell associated. And then it's going to kill the donated tissue. And this is usually going to be destroyed by just simple inflammation. So remember, we have vascular, the vasculature recruits neutrophils, the antibodies are going to activate your monocyte macrophages, and you're going to get vascular thrombosis. Now, this can be avoided by careful ABO and HLA cross-matching, and this hyperacute rejection is actually quite rare now because we know so much about it. And again, these preformed antibodies are binding to the tissue, and in this case, they're activating complement, which is going to cause inflammation in the tissue, and you're going to get a normal, typical inflammatory response. Now, the next type of rejection is called acute rejection, and this is a type 4 hypersensitivity. And so this is going to take place within days or weeks after transplant. And it kind of coincides with T cell activation. And so basically what's going to have to happen is you're going to have donor dendritic cells. I don't know what it says here. So you have donor dendritic cells. So we have our autologous dendritic cells, I guess will be in green. And then we have our donor dendritic cells shown here in our yellow. So when our autologous or our self-dendritic cells go to the donated tissue, pick up antigens, bring them back to the draining lymph node, and then present them to our T cells, this is known as indirect. And then when our dendritic cells are going to migrate from the tissue, these are our allo DCs. This is going to be direct activation. You're basically taking dendritic cells directly from the tissue, going to the draining lymph node, and activating the T helper cells. Now keep in mind that these donor-recipient pairs are HLA matched as closely as possible. And so the MHC molecules on the donor dendritic cell can react to, or can activate our T cells because our T cells can recognize the allo MHC molecules because they've been matched. And so regardless of which dendritic cell is going to activate the recipient T cells, they get activated. And then the T cells are going to proliferate, they're going to migrate into the donated tissue, and then they're going to have the T cells respond to donor peptides presented on the MHC complexes within the actual tissue. And so the CD8 T cells will then start to kill the tissue. So this is your cytotoxic T cells killing the tissue, and these are your T helper cells, of course, secreting cytokines. The example is a kidney, and so the survival of the kidney is going to be related to the degree of mismatching, and it's especially important with the kidney for HLA-DR loci. Oops, A. Sorry about that. Okay. Um, Again, acute rejection is going to occur or more when there's more HLA mismatches. So as you mismatch, your likelihood of rejection or success is going, the likelihood of success will reduce and rejection will increase, of course. Now you can see here that there is no 100%. So even if you have a perfect match, you still have some possibility of rejecting the tissue. And that's why everybody should be on immunosuppressive therapies for their lifespan when they have a donated tissue such as this. Now, the other thing that can happen is that, again, most of the rejections can be caused by mismatched HLA. And so what that means is that uh, the tissue is presenting HLA antigens on their MHC molecules, and the activated T cells migrate to the tissue and target those cells and kill them. There are also minor histocompatibility antigens, and minor antigens are proteins that have different amino acid sequences in donor and recipient, but they are encoded by genes not of HLA. So we have minor histo. And these equal antigens that are different between donor and recipient, but are not HLA. So that means it can be any antigen that is different can also lead to a rejection. And so minor histocompatibility mismatches are not going to be picked up by our standard mechanisms of matching donor-recipient pairs. So tissue typing techniques that pick up the HLA matching will not pick up these antigens. And the term minor antigens is used because the major rejection is thought to be major histocompatibility complex. So when the major histocompatibility complex are matched, but you still get rejection, the rejection antigens were termed minor because they're not HLA. It doesn't mean they're not minor, they still cause rejection. So the minor antigens are going to cause about a rejection of about a third of all the transplants that are rejected. Okay, so acute graft rejection again is going to be where you're going to have major histocompatibility matching. However, it's not possible to do minor histocompatibility matching. And then this is going to cause rejections. And oftentimes, because of these minor antigens, even if you have the best HLA matching, you're going to put the person on a series of prophylactic therapies. So you're going to have to match HLA, cannot match minor antigens. And so immune suppressive therapies are used. And this can be cyclosporin, corticosteroids, mycophenolate, things such as that. So acute graft rejection of is shown with respect to the picture here is going to be the biopsy of a kidney which has lymphocyte infiltration into the graft. And this type of biopsy picture is consistent with acute rejection of the renal tissue. Now, some things to keep in mind is that the tissue that is being transplanted has to be handled with care because if their donated tissue has been damaged, so the kidney that's being transplanted was not treated properly, um, put on ice, they can have hypoxia develop in it. And then these damaged tissues are going to have those damage associated molecular patterns. So, oops. So it's almost like they are already inflamed. And then so these damage-associated molecular patterns will trigger inflammation in the donated tissue, which can, again, lead to rejection. All right, the next one is our chronic rejection. Chronic rejection is going to go for months or years. And then what's happening in chronic rejection, this is going to be mediated by T cells. And so you're going to have a CD4 influence that is going to go into the tissue, and it's going to activate your macrophages, for example, and it's going to induce inflammation, which gradually over time will lead to rejection of the tissue. So this is going to be T cell mediated. And primarily it's going to be CD4 because it's not the acute rejection, which is mediated more by CD8 T cells killing the actual tissue using MHC class 1. CD4 T cells, remember, are just our helpers, so they release cytokines plus help macrophages, for example, in the tissue become good at killing. And so you're going to have inflammation. Sometimes you can have rejection over time due to autoimmune disease. And then other times it can be repeated acute rejections that over time chip away sort of at the donated tissue. And so chronic rejection is a little bit more complex, and in some cases it's hard to determine exactly how the tissue was rejected. Okay, so here's just a list of tissues that have been or are commonly transplanted. And on the top is the easiest to transplant, which is the cornea. And down at the bottom is the hardest to transplant, the stem cells. And so in between are just various levels. So remember, our liver, you do not have to have HLA mismatching or matching. So HLA matching is not needed. For your kidney, the HLA will improve graft survival, but is always going to be on immunosuppressive drugs. Pancreas and kidney are oftentimes going to be transplanted together. And in the heart, of course, the heart, you have HLA mismatching is not always possible due to the emergency need for a heart transplant. And so heart immunosuppression therapy is quite aggressive. And then the type of donor for a cornea is usually going to be cadaveric. You have liver is going to be either live or cadaveric post-mortem. Kidney, again, live or cadaveric. Stem cell transplant is always going to be live. And so, again, handling of the tissue, making sure that it is not damaged, is not induce inflammation just simply because it has already started a hypoxic type of reaction is important. And then the graft survival. So cornea, the easiest, about 90%, and then it goes down through different gradients. And so survival has increased, obviously, because we understand matching of those major histocompatibility antigens. We understand the need for immune suppressive therapies, and we have a variety of immune suppressive drugs that can be used. And so both of those together have increased survival of the grafts after the transplants. Now, for stem cell transplant, these are going to be typically hematopoietic stem cells, and they're going to be used to um, replace either a myeloid or lymphoid cell, which is for some reason presenting with disease. So you can have, for example, a primary immunodeficiency, which is the easiest to think about because in a primary immunodeficiency, you have deficient cells, whether they're neutrophils without not able to do oxygen burst, or if they're T regulatory cells that can't express FOXP3, so you have widespread autoimmunity. You can use the hematopoietic stem cell to try to give the patient a new set of cells that will be functional. And so there are risks associated with it. The best outcome is to use autologous stem cell transplant, in which the bone marrow from the individual is removed, frozen, and then following, for example, a lot of chemotherapy, you can give back their stem cells. So there's the autologous transplants, of course, are going to be taken very well. They're not going to be rejected. However, you can't do that for a lot of patients because those autologous cells sometimes carry the same defect. So if you have neutrophils that can't do the oxidative burst, typically the stem cell is defective in those genes as well. So then you have to move to the allogeneic stem cell transplant. And this is more risky because you're basically giving someone else's immune system. And as we know, those new cells might see the new person, the recipient, as foreign and attack them and create widespread damage to the tissues of the person. So you have to, of course, match, and even well-matched donors, mortality rate can be high as 20%. There is also a different disease that's associated with this, which is graft versus host disease. And you don't typically see this with solid transplants. But with respect to the stem cells, you're giving them, again, new T cells, new B cells, new neutrophils, etc. And those, again, can be released. And if they do have some reactivity to recipient MHC, HLA molecules, you can get, again, damage to the actual person. So because there's a high mortality rate and because there is the graft versus host disease, the allogeneic stem cell transplant is carried out under certain conditions. And so again, it goes back to, is there some other treatment available? And when there's no other treatment available and these other conditions apply, then this allogeneic stem cell transplant are attempted. So you have some sort of malignancy associated with the recipient's T or B cells or myeloid cells. Or there's aplastic anemia. You also can have primary immunodeficiencies, such as severe combined immunodeficiency, in which the person would die if they did not get a transplant. And so under those circumstances, you can try to do a stem cell transplant. So with respect to a stem cell transplant, there is always going to be a risk of the donated transplant, of course, attacking the recipient. There are also risks for infection. So you can have a period of neutropenia, and this is going to be the conditioning associated with the stem cell transplant, and you can have risk of septicemia associated with that. If you have graft versus host disease, you can often get T cell numbers reduced, and you also have a risk for infections. And then also you need to keep in mind that it takes time to replenish a immune system. It just doesn't happen overnight. We know through the development of the fetus, the immune cells slowly develop. They don't really reach your antibodies don't really reach the levels in an adult until about the age of 5. So again, when you're depleting someone's immune system and giving them a new immune system, it's going to take time for that new immune system to populate the body and to respond to all of the different microbes in the environment. In addition, B cells are going to take time. And so this is going to lead to recurrent infections with common bacteria in the environment that normally would not pose a problem, such as pneumococcus infections and Haemophilus infections. And so the stem cell source is important too. So we have bone marrow is the usual source of stem cells. And bone marrow, of course, is going to require aspiration of donor marrow. And this is painful. It's going to be done under general anesthesia. And so there are risks involved with taking bone marrow from a donor. There is peripheral blood stem cells. And so and these is going to be the donor is treated with growth factors. Such as colony stimulating factors, and this increases the number of circulating stem cells. And then the stem cells are simply removed from the blood and they are collected. There's also cord blood, and these contain a large number of stem cells that can be frozen. And so these can be, you can now collect cord blood from a fetus, a baby, and then store it in case the baby has something that they need a transplant for later in life. And so there are, you can have banks of cord blood cells. And an advantage of this is they are also immature and they're less likely to cause graft versus host disease. Okay, and so cord blood is only going to yield enough stem cells to transplant into children or small adults, so that's the other side effect of that. Now, conditioning is going to be a process of giving high doses of chemotherapy or radiotherapy, and this is going to destroy recipient stem cells. Basically, you're irradiating the recipient, and it's going to target cells that are active in dividing, and so it's going to, the white blood cells are very susceptible to this. And so you need to get rid of the recipient stem cells that are defective in order to transplant the donor stem cells. So this is also going to create a space. So the space is again where the new lymphocytes or leukocytes will be filling. And then it's also going to reduce the risk of the recipient's own immune system rejecting the donated stem cells. Now, because you are giving the recipient a new immune system to replace some defective or malignant immune system, you have the potential of now the graft, which is the new stem cells, attacking the host. So this is referred to as graft versus host disease. And so graft versus host disease is going to be donor T cells. My dog. Graft versus host disease is going to be donor T cells are going to respond to some recipient antigen. And these can be either the major or minors. So even if the donor and recipient are going to be identical, there are minor antigens that can have a risk for causing rejection. In addition, you also have put people on immunosuppressive drugs to prevent graft versus host disease, and this can lead to risks of infection, just like any other type of immune suppressive. Oops, graft versus host, sorry, GVHD. So this can increase infections. Now, acute graft versus host disease is going to occur about 4 weeks after the stem cell transplant. Again, this is T cell driven, so it has sort of that acute timeline. And it's going to involve widespread inflammation, widespread attack of the skin, gut, liver, lungs. It has about a 70% mortality rate. Chronic graft versus host disease occurs later and affects mostly the skin and liver. So we have acute, and this is going to be skin, liver, gut, lungs. And we have chronic, which is going to occur later, and it affects skin and liver. Now, one thing that can be done to reduce graft versus host disease is to remove the mature T cells from the pool of stem cells that you are injecting into the recipient. Okay, so if you basically we have ways of sorting the cells out. You can use flow cytometry to do this. And you can take the stem cells, which is still taken from the blood. So in the blood, you're going to have mature T cells. And so you basically take those blood leukocytes and you sort them into stem cell only and then other. And so you only inject the stem cells and the rest of the white blood cells don't get injected, for example. And so this will, this technique will help to reduce the risk for graft versus host disease. However, if you do T cell depletion, you unfortunately increase the risk of graft rejection. So you are reducing graft versus host disease, but you're increasing the potential for rejection. So the donor T cells can also target, react against recipient tumor cells, and so this was identified as a consequence of this graft versus host disease. So what this means is that you have a person who has a tumor and leukemia, for example, and the donated stem cells are able to mount an immune response against the leukemia cells and eliminate them. And so this became known as a beneficial graft versus leukemia effect when you do the stem cell transplants. So again, this is very difficult transplant to do. It's one of the most difficult. You, of course, want to match, just like any other transplant. But even if you match, you still can get rejection, and you can get graft versus host disease. The depletion of T cells is before you give the donated stem cells, is complicated because it can lead to an increase of graft rejection of the transplanted stem cells. So whether or not to deplete T cells is going to be based on a case-by-case basis, and it has a lot to do with the degree of matching of the donor. Because if they're not as closely matched, you will want to deplete the T cells because you don't want the mature T cells to potentially target the recipient tissues. And when you have more of a match, you can go through and not deplete the T cells, and you have a higher chance of not getting rejection. So it's a balancing act as shown here. All right, so we have tissue typing techniques. So of course, this is going to be important for allogeneic transplants, which are the majority of transplants. So you want to have as closely matched HLA, those major histocompatibility antigens, as possible. And you also want to make sure that the donor has no antibodies against the recipient. And so we can do this by testing for in a process called the cross-match procedure. So these are going to be, tissue typing and cross-match are going to be very important in reducing the risk for rejection and complications. So HLA typing is where you have the patient who is going to be receiving the transplanted tissue is typed. And so you know what sort of HLA alleles are in the recipient. So that means that they're typed. Now we have different HLA alleles in all of us. There is many molecular biology techniques that are going to be used to identify or type an individual's HLA. You have to go through their genes and sequence them. You go and look at siblings and family members first to see if they have a good match and if the person is living. However, there's only a 1 in 4 chance that a sibling is identical, and if an identical sibling is found, then they can act as a donor. Otherwise, people who need solid organ transplants, especially kidneys, go on a waiting list for a cadaveric organ, somebody who has passed away suddenly who has a matched kidney. And then the organ becomes available, the donor is typed, and then you search the database for a match in the database. And then when an organ is extended across a lot of states, the wait time for a matched tissue can be months before a well-matched organ becomes available, so people have to wait. So in this case, in the picture over here, it shows the patient has, purple, has developed renal failure and needs a kidney transplant. The patient has been typed at the A, B, and DR loci. And so you can see they're A5, A2, B13, B7, DR1, and DR2. And then the patient is then going to await a transplant. So these are all the potential donated tissues. And so you're looking for one that matches closely to the patient in purple. And so a potential donor is HLA typed. and then the kidney gets sent to the hospital where the HLA recipient is in the registry and is waiting. And so that's kind of how these solid organ transplants find their way to the donor and recipient. Now, registries are going to be used also for patients who require stem cell transplants, and these are mostly going to be of volunteers who have agreed to be part of the donor pool and have been HLA typed. So there are blood banks and blood areas that will collect your information, type you, and then when a person who is in need of a stem cell transplant matches your type, then you will be contacted and asked to donate stem cells for that patient. Now, cross-matching is going to rule out preformed antibodies against the donor HLA, and this could cause hyperacute rejection. So cross-matching is to catch pre-existing antibodies, which can cause hyperacute rejection. And then the antibodies, again, they could have been, you could have developed antibodies to ABO antigens because you had a blood transfusion, or it could have been a woman during pregnancy exposed to fetal blood, etc. So there are many ways that you can have these antibodies present, and it's just important to check for these before you transplant the tissue, because you don't want the tissue to be rejected within an hour of the transplant. So in the cross-matched test, the donor B cells are going to be incubated with the recipient serum. And the donor B cells are used because they express both class 1 and class 2 molecules. And then the presence of antibodies to the cells can be tested against both of those potential HLA mismatches. And so here we have a kidney and a blood sample from the donor having brought to the hospital. And so you have the donor B cells are mixed with recipient serum. And in this case, you have preformed antibodies, and the recipient serum coat the donor B cells, and the transplant therefore will not move forward. In this case, the recipient has no antibodies against the donor cells, and the transplant will then proceed. So you need both the typing and you need the cross-matching pass in order for the solid organ to be transplanted into the recipient. Now, finally, we're moving on to immunosuppressive drugs. So immunosuppressive drugs, again, are going to be important to prevent graft rejection, typically more for chronic, so you get past the hyperacute rejection. And then you want to prevent acute rejection, which is caused by T cells killing the donated tissue. And you want to also prevent chronic rejection, which is going to be inflammation mediated by CD4 T cells that will gradually chip away at the donated tissue and lead to rejection. Also, you can use immunosuppressive drugs, and you have to for stem cell transplant to prevent graft versus host disease. And so we're going to have immune suppression drugs, tacrolimus and cyclosporin. And these guys are going to inhibit T cell signaling. And so even though you might have a dendritic cell trying to stimulate a T cell, these two drugs will prevent that T cell from actually being activated. We have some monoclonal antibodies that are going to bind to IL-2 receptor as an antagonist, and it's going to prevent IL-2 from binding. So then here again, you have your activated T cells. They're going through the activation process. They're releasing IL-2, but your monoclonal antibodies are able to prevent IL-2 signaling, so that T cell, even though it's activated, won't divide into large numbers. You also have rapamycin, which is going to, again, target the IL-2 signaling pathway. and it's going to prevent the positive signals to replicate. Azithromycin and mycophenolate are going to inhibit T cell proliferation as well. And so, again, all of these are not preventing the activation or the interaction of the T cell with the MHC molecules and seeing that signal 1, signal 2. All of these are really focused on trying to prevent the T cell from getting activated, proliferating to large numbers, and causing a lot of damage. If you keep the T cell numbers down, you're going to minimize the amount of damage. All right, so you have also the possibility of xenotransplantations. So even though we have immunosuppressive drugs, they have the side effect, of course, of increasing potential for infections. In addition, we still have long waiting lists for organ transplants because of the matching that's required, as well as the cross-match tests. So it's thought that the number of people waiting for transplant is doubling every 10 or so years. And there is too few human organs available because the need is so high. And it's currently about 10 patients die each day in the United States while they're waiting to receive a vital organ transplant. And so xenotransplants from other species are thought to be an alternative in the future. Hang on. Sorry about that. So again, we're in the future, it's thought that maybe xenotransplantation can kind of fill the gap. But there are a few problems with these xenotransplants that have to be overcome. So obviously, when you think of sort of another species organ being transplanted into us, primates are on the top of the list. And so for primates, they're going to have differences in their sugars, their side chains. They have different arrangements of sugars than we have, and these can be potentially immunogenic. So they have a galactose A1,3 galactose sugar motif on most of their cells, and our immune system can recognize this galactose A1,3 galactose motif. And so if you test humans, we do have antibodies to that. We also have natural antibodies that can recognize the galactose A1,3 galactose on xenotransplanted organs, and this will activate complement and trigger the hyperacute rejection. So they have different sugar motifs. And these are immunogenic. Also, complement inhibitors from other species don't inhibit human complement. And so this is a molecular incompatibility, and xenotransplanted organs tend to activate human complement. And then, of course, as you know, activation of human complement will trigger inflammatory responses. Inflammatory responses in a donated tissue will lead to rejection. There are transplanted pigs that are being developed with a reduction in the different sugar motifs. And this is to prevent those hyperacute rejections. Pigs are used, again, because their organs have similar size to humans. They're able very easily to breed in captivity as well. But there are two main problems with pigs as well. Acute rejection may occur because pig proteins elicit a T cell response, so they have antigens, minor antigens. It's just like any allo type of transplant. And even if you have pigs in an environment that reduces the potential for pathogens, etc. Pigs have what we call endogenous retroviruses, and though these have not been known to infect humans, they could do so after transplantation. And transplanted pig viruses are more likely to infect recipients, especially those on immunosuppressive drugs. So, so I should say endogenous. So we'll talk about this more in micro, but endogenous retroviruses are part of humans as well. We have our own human endogenous retroviruses, or HERV, is what they call it. And so it's thought that we have evolved with this retrovirus. And so other species have their own versions of these retroviruses. So it's possible that when you transplant a pig organ, they will have these pig endogenous retroviruses that don't cause a problem in pigs, but may cause a problem in humans, especially those recipients, because they're going to be on immunosuppressive drugs. In addition, in humans, we do screen for known human pathogens before a transplant is given. And there have been cases where rare, I guess, a zoonotic infection. So, for example, so there's a virus called lymphocytic choriomeningitis virus, which is endogenous in rodent populations. And so there were cases where somebody received an organ transplant from a person who was infected with LCMV, and LCMV does not cause a severe infection in humans. However, when you transplant it into an immune compromised transplant recipient, LCMV causes meningitis, and some of those transplanted patients died. And so now we screen humans for not only the other pathogens known, HIV, etc. It's also screened for LCMV. But when you go into an xenotransplanted tissue, we don't necessarily screen pigs for all of the pig potential viruses. And so there's potential for transmitting those viruses to humans during the actual process. Okay, so that is all for transplantation.